So welcome back. I'm excited to kick off our afternoon panel. I think all of our panelists have their video turned on and are ready to go. So to further inform us about issues related to population-based total cost of care models, we've invited a variety of esteemed experts from across the country. They represent many points of view, including providers, payers, academic policy researchers, and patient advocates. This morning, we learned about a handful of specific initiatives and some research findings. I think these panelists will offer some additional perspectives that will help us explore our theme. PTAC members, you'll have an opportunity to ask our guests questions as well. The full biographies of our panelists can be found on the ASPE PTAC website, along with other materials for today's meeting. So I'll briefly introduce our guests and their current organizations. First, we have Jennifer Kowalski, who is the Vice President of the Public Policy Institute at Anthem. Dr. Emily Maxson joins us from Aledade, where she is the Chief Medical Officer. Next, we have Judith Stein. She is an Executive Director and Attorney at the Center for Medicare Advocacy, which she founded. And lastly, we have Dr. Gail Wilensky, an economist and senior fellow for Project Hope. So let's get started. In Medicare alternative payment models, all Medicare Part A and Part B services are typically included in benchmarks labeled total cost of care. Based on your experience, what types of services are typically included in this calculation? And what kinds of additional services could be appropriate for inclusion in future population-based total cost of care models? And what would be the rationale for including this? Dr. Wilensky, I'd like to start with you.
Costs that are included are the costs that are part of Part A and Part B. Therefore, you would include hospital, inpatient, and outpatient. You would include physician expenditures. More recently, the use of both outpatient as well as inpatient prescription drug expenditures. The question that has been around for a long time is that there are a variety of services that are not included in Part A or Part B. Some of them are included in Medicare Advantage plans, vision and some of the hearing or alternative health types of payments. And one of the questions that has been raised is, should the definition be broader to include health care that is not a part of traditional Medicare, or should it be focused primarily on traditional Medicare as that which is under the direct purview of the CMS and Medicare programs?
Great, thank you, Gail. Jennifer?
Sure, thank you very much for having me today. And at Anthem, we're using these models in both the Medicare space as well as the commercial space. So I might offer sort of a little bit higher level approach to this. We sort of think about it in two prongs when we think about, what services or what spending should be included in a total cost of care model. And I would describe the first prong as sort of what degree of control does the provider have over impacting the services or spending to be included. So for instance, if you want to think about prescription drugs, if you think about a primary care provider, what levers do they have to control the spending on the drugs that are prescribed outside of their office? So if there's a whole set of specialists that an individual might see outside of that provider's office, do they have any degree of control over what's being prescribed and the costs of those drugs? And in some cases, the answer to that is no. And so perhaps it doesn't make sense to include that in the total cost of care benchmark. On the other hand, you may have contractual alignment between a PCP and a group of specialists probably more common in some of the fully capitated models where the PCP can build out a specialist network. And in that case, perhaps it does make more sense to hold the PCP accountable for the drug spending in those scenarios. And kind of likewise, when we start to think about some of the non-medical benefits that are being added to health plan benefit designs today. So if you start to think about transportation or some of the things to address health-related social needs, like maybe a patient with a COPD needs an air conditioner, for instance, should the PCP be on the hook for or accountable for, if you will, those types of costs as part of a total cost of care calculation? And again, I think the answer goes back to what sort of control does the provider have over the spending on those types of services? Is the plan largely, the one making the decisions about who gets what and when and to what extent? Or is the provider, maybe a large health system that said, hey, give us a care management fee that includes, some of these services. And as part of that management, we want to be the ones to, provide transportation or to provide and address some of these social drivers of health type things. And in those cases, it probably does make more sense to include that in the total cost of care measure. And I think related to this is sort of the second prong, which is, what level of capabilities and services does the provider really have to support the patient population, to support a clinically complex population? And so how much financial risk can you expect the provider to take on for that set of services? And then I just want to address, before I wrap up on this question, to some extent, the services and components that are included in total cost of care models have to differ across payers, across lines of business. So if we go back to the prescription drug example again, if you think about the commercial insurance population, so the large employer group population, in a fully insured product, individuals generally get their medical and drug benefits from the same health plan. So we can put the drugs in the total cost of care calculation for those individuals. But in self-insured employer arrangements, more commonly employers kind of break up who manages which parts of the benefit. So you may have a health plan managing the medical side, but you may have a totally separate PBM managing the drug side. And so operationally speaking, it's much more difficult to include drugs in the total cost of care calculation in those cases. So I think we'll get into some of this in the second question, but there is some variability for a variety of reasons.
Great. Thank you, Jennifer. Judy?
Yes, thank you, and thank you for having me today. I don't pretend to be an expert in total cost of care, economic issues. My expertise is in 36 years of representing Medicare beneficiaries. So from the beneficiary's point of view, all these models are at best confusing and not understood, and it's increasingly concerning. The incredible number of mergers of large health organizations. In Connecticut, we have, for example, where my organization is based in both Connecticut, Washington, D.C., and then attorneys around the country. But increasingly, our healthcare is run by two very large hospital organizations, which have kind of eaten up primary care practices, SNFs, nursing homes, and home health agencies. And that tends to limit access to care for beneficiaries, for patients, to those affiliated providers. So I'm concerned that the continued look to total cost of care as has been experienced within these large affiliated hospital systems and as understood or experienced, I should say, within Medicare Advantage by beneficiaries has not been shown to increase quality or choice, real choice between by beneficiaries to access to a full range of providers that they might want to see and that they can understand from the beginning of the year to the end will be available to them, both within their geographic area and in the Medicare traditional world versus Medicare Advantage. throughout the country. So I'm very interested in what the risks, if you will, quote unquote, are to beneficiaries and what the advantages are to patients, and will they pan out in practice? Because finally, I'll say that the appeal system, the review systems, the ability to speak directly to providers versus in Medicare Advantage, the Medicare Advantage plan, and now to the AI, the proprietary entity that may be making determinations regarding coverage, is become more and more opaque, even for professionals who represent beneficiaries. So there are some warning signs that this is not the way to add to choice or quality of care for the people who need it. Thank you.
Thanks, Judy. Emily?
Thank you. I just want to emphasize the Part D question. We at Aledade bring together previously unaffiliated primary care practices and form accountable care organizations and help them succeed in the transition from fee-for-service to value-based care. And we're managing contracts beyond Medicare, including Medicaid and commercially insured patients. And so what we find is that there's an amazing amount of appropriate pharmaceutical stewardship to be had. And if we don't include Part D prescriptions in total cost of care, we miss out on the opportunity to shed light on that and to bring that management that can benefit patients to bear. We do this for commercially insured patients, and there are a lot of generic opportunities for switching that bring lower cost share to the patient, and I do think that beneficiaries could benefit. I know that it's administratively complex, but it may be worth, if we're considering different services to carve into total cost of care and include that aren't there already, it may be worth figuring out that administrative complexity so that we may better manage Part D prescriptions and their associated costs.
Great, thanks, Emily. I'll now open it up to PTAC members for any follow-up questions. You can either raise your hand or simply start speaking. As you're thinking about potentially some questions, just to add on to this Part D question, because Jennifer, you had mentioned for primary care, if they don't, it doesn't appear they have sort of control over the drugs, maybe it doesn't make sense for them to be accountable. You could think of oncology as an example. But on the other hand, as they're thinking about total cost of care models in general, it seems that it becomes more complicated if you sort of parse it by, sort of drug categories or specialty categories. So, Emily, you may have and others may have a comment as well about this, particularly around Part D, which is something we talked about yesterday as well with some of the panelists. I'm just curious your further thoughts on that.
Yeah, I think that's a great point. And I don't want to give the impression that we never include drugs. We certainly do in some of our models. I think the other thing to note is that in total cost of care models, cost is not the only metric, right? There's a whole set of quality measures as well. And so while you may not necessarily be holding a provider accountable on the spending, you may still be holding them accountable on things like medication adherence or generic utilization, or things that are more easily, measured, or that they can be, more accountable for without the financial risk so tightly tied to it. So I think there's multiple ways to sort of come at some of the same aims, and it doesn't always necessarily need to be part of the cost of care benchmark.
I think you need to be careful about what happens to the costs that are excluded. I'm sympathetic to having costs included that are outside the control of a particular group or payer. But to the extent that these are significant costs, and the example of oncology drugs certainly would be one of those examples, you really then are finding yourself excluding what might be the determinative factor of real importance in total cost of care. And so I think that It's not obvious which way you are better off in terms of understanding what the variations in total cost of care are and who would be accountable if not putting it in the single metric.
Any other comments before we move to another?
Sure.
Yeah, oops, excuse me.
Oh, please, after you.
Let me explain one area of Medicare and healthcare where there's kind of a total cost of care that we're at the Center for Medicare Advocacy very familiar with. The models are both at the nursing home SNF level and at the in-home health. Let me talk about home health for a minute. In January 2020, the patient-driven grouping model came in, PDGM. It pays the agencies now per 30 days for 30 days for all the care that is provided to Medicare beneficiaries under that are available under the Medicare program. So it's one payment, one type of payment based on the various services that are received by the beneficiary. But what happens sometimes, very often, is that you follow the money. So it used to be that people could get home health aides, which are part of that pocket of services that are available under Medicare, as well as therapy and nursing, which are also coverable. But as the payment system came into play, we found more and more that the services were not provided or were provided at the beginning of service, which the agencies are paid more for, or for people who have hospitalizations because they're paid a little bit more for that. And then as the 30 days went on, they did not necessarily receive the full package of care that had been ordered by their doctor. And very concerningly, increasingly, even before COVID, there was less and less home health aides available and therapy because the agencies are no longer paid more under this payment model to provide those services. So an air of caution with regard to what is included in this total cost of care, and is it truly the care that is then going to be provided to the beneficiaries in need?
Yeah, thanks, Judy. Before moving to Emily, on that note, and you brought this up initially around certainly a lot of confusion potentially for beneficiaries. Any thoughts on how best to inform beneficiaries about their choices, or when when they may be now in a total cost of care model moving forward?
Well, as you may know, most beneficiaries, if they're in a Medicare Advantage plan, don't make a choice after their initial decision. That's according to the Kaiser Family Foundation, between 20 and 30% never make a change. 20% of those who are in such plans didn't choose, but were set in such plans by their former employer or their sometimes the state or municipality. It's very hard because the plans aren't standardized. I think standardizing choices may not be popular in some areas, but for beneficiaries, it's very, very important. You can choose Medigap plans much more easily because there are not 50 of them for most people. There are a dozen, and they are standardized. I think that's important. Cutting down on what's allowed to be marketed versus people getting education from the Medicare agency is important. Having clarity with regard to what's an ACO, what's a Medicare Advantage plan. I mean, there are just so many myriad models these days. It is, in fact, very confusing. And I think that's part of the problem that professionals need to take into consideration, because it gets to a point where, I'll give you an example. 2 years ago, I was asked by my daughter to go to the store and get some granola bars for my grandchildren as they were coming to visit. I stood in front of the granola bars and realized there were dozens upon dozens of granola bars. I had no idea if these kids preferred the chewy kind, whether the parent did or didn't want chocolate chips in them, etc. It may sound like a silly metaphor, but we need to understand that choice. There's a book called Paradox of Choice by a professor at Swarthmore. This is an increasing problem. It is difficult to make a choice, And when there's so much choice, the average beneficiary has 39 MA plans alone to choose from this year, it's almost impossible to properly educate. And I consider that my organization's job in part. Thank you.
Yeah, thanks, Judy. Appreciate that. Emily, I don't know if you wanted to make some comments on the question on
Well, I
Part
can
D.
wait for the next
Okay.
question. It's related.
Okay. Great. Thank you. Okay, so next question. Do you think there should be a single standardized definition of total cost of care in future population-based total cost of care models? Why or why not? So this time, Jennifer, we'll start with you.
Okay, great. Thank you. I think I probably hinted at my answer to this one in my response to the first question a bit. But no, I don't think there should be or really can be a single standardized definition for total cost of care, at least not if we're thinking about, there's going to be one thing that applies to every plan and every provider and every line of business out there. And, this is for, to some extent, some of the reasons I started to get into in the previous discussion. There's different degrees of provider readiness in terms of taking on some of this risk. There's different expectations and different incentives that we might want to put in place in terms of providers' ability to be accountable for services and spending. There's different benefit structures across employers, across Medicare versus Medicaid versus commercial, and so forth. In addition, I'd note that, like, in our experience, particularly in the commercial space, we have a starting point. There's sort of a template that we use for these types of models. But, if you think about the large self-insured employers, they have a desire to customize sort of every aspect of their benefits, including, what these sort of models look like. Sometimes large health systems are far more advanced on these sorts of value-based arrangements. They want to be able to customize to their own particular capabilities. And so there needs to be some room, there needs to be some room for that. There needs to be some room for innovation, but there certainly doesn't need to be unlimited variation. I think we can probably think about, grouping providers or grouping lines of business into, kind of a couple of situations of, how much risk can they take on, what suite of services might they be accountable for or able to take control for, and at least have some, commonalities and starting points across, some, X number of groupings, for instance.
Great. Thanks, Jennifer. Emily?
I'll take the opposite perspective. I would love to see a single standardized definition of total cost of care, especially for Medicare models and across Medicare models. I think that using multiple versions of total cost of care ends up creating the possibility that providers are needing to choose between models, and sometimes they would opt to do this based on perceived favorability of the benchmarking, which gets you into an arbitrage situation rather than really focusing on the tools that they need to transform care. Even if we had a standardized definition of total cost of care, we would still have plenty of room for experimentation with new payment and service delivery models. I think we saw this with direct contracting. We had a lot of organizations that we witnessed really carefully dissecting the direct contracting benchmarks to see whether they were going to be more favorable than Medicare Shared Savings Program, and then we're going to make decisions based on that. And it really didn't end up as a productive use of energy and resources. The other thing that I wanted to mention related to the previous question and tying into this one is that we've learned a lot in engaging providers in this space. And when we started doing this, we really recognized that we needed to encourage a frame shift so that practices could really embrace the total cost of care. We know that physicians are used to being evaluated on process measures that they know are in control, right? So did every patient who walked into their office get a blood pressure? Did the PCPs prescribe the appropriate medicine? And it was less natural at the beginning for our PCPs to think about taking accountability for whether the patient with severely poorly controlled blood pressure actually took that medicine, whether they followed the dietary recommendations that they received, whether they needed the emergency room, and whether they actually avoided that stroke or heart attack. And once you really get buy-in from this practice group or these providers that anything that happens to the patient is your responsibility and that of the accountable care organization, you see creativity and innovation start to emerge. And I worry that carving out certain disease states or overly customizing and allowing different cost of care definitions and carve-outs, disincentivizing truly jumping into the value-based care canoe when you have one foot in each value-based care and fee-for-service.
Great. Thanks, Emily. Gail?
I think that within the components of total cost of care, there ought to be standardization. But because some models may include a different number of components, that it is desirable to not only have a single metric of total cost of care. So I would say that it is a useful concept when viewed in terms of the components, but it would become too rigid and probably not useful for some of the models that are being tried on occasion to have a single standardized cost of care. So continue the flavor that raises, but not apply it in a rigid manner.
Great. Thanks, Gail. Judy, any other further comments on?
No, except that I think from the point of view of what is beneficiary facing, is less complicated and clearly understandable, and therefore some standardization would be valuable so that they know what they're comparing to.
Great.
Judy and I have had these conversations for probably the last 30 years.
Bless you.
Yeah. I'm going to open up to PTAC members, and I apologize. There were two members had questions for the first, but I suspect that they may carry over. So, Bruce, I'm going to turn to you for your question.
Question for, I hear an echo. Do you hear an echo? No? Okay, good. For Gail Walensky, as an economist and a former Medicare administrator, what's your take on the argument about large models versus that are primary care oriented for the most part, and smaller models that are specialty oriented on them? Can they coexist, and how can they best be made to coexist?
Well, they need to coexist. The only alternative is to look at those organizations that include all of the physicians, primary care and specialty care. To the extent that you can have some agreement of the minds on definitions, on operationally how to define the concepts in ways that are not inconsistent with the care that are being provided, you might be able to reduce a little of the tension. But there is an awful lot of friction between how much of what goes on in the specialty world ought to be under the responsibility and purview of the primary care physicians. I mean, this has been going on for a long while. To have them be too separate and independent loses the whole point of thinking about a total cost of care. But you get into this dilemma of how to have attribution to groups who have no control and responsibility. So it is going to be a blend of trying to get it right so that you don't miss the important components of control.
Sorry, I muted myself. Yeah. Larry, I think you had a question. Thank you, Gail. Larry, I think you had a question.
Yes, I do. I've really enjoyed this discussion. The different flavors from each of the speakers has been enticing to listen to. Judith keeps catching my attention because my personal focus is a patient-focused one. And how do we move design from provider focus to patient focus? That really should be our challenge. As a physician, I should be prescribing the right drug for the right patient at the right time for the right reason, not because the health plan wants me to use a biosimilar. And oh, by the way, if I use that biosimilar, I may make more money, but the patient still pays the same copay and deductible. And the patient may not know they're getting a different drug. So how, in our design of these programs and in talking about total cost of care, don't we owe the beneficiary a definition of total cost of care so that when they're in the market looking at other other plans, other alternatives, they can tell what they're getting for the money that's being spent?
I'd like to respond to it's an issue I think that goes to what Larry has raised that's come up before in related discussions, and that is trying to distinguish between having agreed upon definitions of component terms, but allowing the total to have some variation depending on the components that are included. I say that because I think you do need to have it understood that when you use a particular term with regard to cost of a type of healthcare, that should be the same across different plans, different organizations. But recognizing, especially because Medicare excludes in traditional Medicare a variety of components of care that may be included in MA plans or other type of plans, and in any case are certainly included in the conceptual total cost of care model, that if the components are standardized, it can be easier to clarify which components are a part of a definition of total and which are not. So it's an attempt to try to have some balance between the issues that Larry raised. I don't know whether he thinks that helps or not.
It does. It does help. It does help. We almost need a Monroney sticker, what's on a sticker of a new car in a showroom, right, so yes, that you know what you're getting in this MA plan, and that you can be an informed consumer.
That's not a bad analogy.
Yeah, but the problem is that there are not only all those different cars on the lot at Hyundai, but there's also the ones over there at VW and at Chevrolet and traditional Medicare is standardized. You can tell what it is, but all those other, if you will, I'll drop the metaphor, MA plans have all different pieces to them. And they are allowed and do market actively. I mean, I'm now Medicare age. My husband's a family doctor, by the way. He's Medicare age. We're pummeled with this stuff. And blessingly, my mother's still alive. And she says to me, I don't know, Judy, is there something different this year? This was last year, because I'm seeing all these ads with Joe Namath. And I'm wondering, whether I should, in fact, make a change this year. So I think it's the marketplace for selling insurance, health insurance, to people who are by definition older and may have disabilities and or age into disabilities. We really need to step back and look at Gail won't be surprised, at what we're doing here and whether it's best. And can you teach all of this? Or is it the paradox of choice? And what people really want is to know this is going to be covered, and in practice it's going to be covered. Because, I deal with all the people who go to the doctor or try to get the drug, and not this year or not this month. And they want to choose between the doctor. My mother wants to be able to go see the cardiologist she's comfortable with. And having had flaming blood pressure problems and lost much of her family to it, She was really scared when this year she chose a certain plan with professional advice, not mine, my colleagues, and a month after, and in end of January, finds that, oh, that plan no longer covers that drug. It was on the plan finder, and it was on the plan's own website. These are the problems that real life people live with that need to be taken into consideration when we theoreticians think through the various models that seem like they might make sense. The consumer will not, and I'm one, will not understand this space, and it doesn't always serve them well.
Yeah, thanks, Judy. And I think that speaks to, in a way, CMMI's current thought about smaller number, and this is in the fee-for-service side of things, smaller number of large models as opposed to, the 50 or so models that are currently in order to try to engage beneficiaries as part of that. Before we leave this question, Jennifer, I'm just curious, as you had articulated your thoughts around total cost of care, are you thinking this as a sort of a transitional period, or is it sort of the ultimate goal for 2030? Again, thinking where CMMI is headed around having sort of a more clear definition, sort of a unified definition around total cost of care.
Am I thinking that there can't be a standardized definition ever, or that in 10 years we could have one? Is that the question?
Yeah, as you're thinking around total, yeah, are you thinking that, could we ever have one, or is it that we need this transition period to ultimately get to one?
I mean, I don't think we're ready for one now. Maybe at some point in the future, if we've moved enough, providers along the spectrum to where everyone is, really comfortably taking risk, then perhaps that makes sense. I sort of like Gail's approach, which is let's define the components consistently, perhaps, and but the actual what's in and what's out can be a little bit variable depending upon the underlying factors of the provider, the line of business, the model. I mean, I also think that when you're thinking about it from a health plan perspective, in a Medicare Advantage plan and a commercial plan, the plan is ultimately, in a way, taking on risk for the total cost of care, right? We're paid a capitated amount. So we're still managing that patient. We're still managing spending. There is a responsible entity for, managing to a budget, if you will. And then we work with the providers in terms of what they're comfortable kind of taking on in terms of accountability for their patients. That's a little different from a fee-for-service model where, yes, CMS is the ultimate accountable party, but they're sort of looking to an entity that's not a health plan to take on some of that management for them. And then I think you do need to think maybe more about if you keep this out or you keep this in, what are the incentives you're creating in terms of who's managing those costs, or what are we doing in terms of access and so forth, and where does that beneficiary and fee-for-service go to is there an appeals process like there is in an MA plan or in a commercial plan, right? Like what's sort of the options for the beneficiary to learn more about what they're getting, not getting, and how to get it covered. Does that answer your question?
Yeah, that's great. Thanks, Jennifer. Jen, do you have a question?
I do. Thanks again to the panelists for a wonderful discussion. We've talked a lot about consolidation of options in the marketplace, not as a means to restrict access or choice, but actually to improve quality of choice, I'll describe it as. We've heard that, as Paul just said, from CMMI leadership and also CMS leadership, that that's ultimately their goal. So my question for the panel is, since we were using a lot of metaphors today, you have a magic wand and you get the opportunity to consolidate the current choices within the marketplace, or organize them might be a better description. How might you go about thinking about solving that problem, or if you prefer to answer the question, to be actually tactical around, what programs might you eliminate and why?
I'll try. I may as well jump in. I feel like I'm anyway a voice that may be sounding a ringing a bell that is hard. At any rate, I think that when we had, first of all, traditional Medicare, we've been trying to figure out what's the right name for it. It is so rarely fee-for-service, which has become like a four-letter word. So it's really unfair to refer to the traditional Medicare program as fee-for-service. It's really made up of a wide variety of capitated rates in different care settings, except for, in some instances, of course, physician services, but hospital, home health, nursing home, they all have capitated rates. And all those capitated rates have produced problems for patients because it's one thing that needs to be looked at, and I'll get directly to your answer to your question, is when you pay a capitated rate, you can't tell whether that service was actually provided for the capitated rate, and especially not with the data that is currently available. Back to the home health arena, for example, the patient may have had an order for home health aides, PT and ST, and nursing, such as one of my clients, for a 60-day period. And that may have been provided for the first 3 weeks, and that's based on how the capitated rate is paid. But by the end of the 60 days, many of those services are no longer being provided and may have been removed gradually over time, with or without the authorized practitioner's understanding of that. So I am using this time to make it clear that traditional Medicare is not fee-for-service, and it's dangerous to keep calling it that with all much respect, because it misunderstands right away what we're comparing to. And also that capitated rates are not the be-all and end-all with regard to fraud and or just misuse. Having said that, the traditional Medicare program and all these models there ought to be parity. They ought to be paid the same amount per beneficiary. If the private models are going to, as was promised, be better for the program and for taxpayers, they should not need 4 cents more on the dollar to provide those services. They ought to be standardized like the Medigap plans were back in the 1990s so that people can understand what their options are. A Plan A Medigap plan is a Plan A plan, whether it's from Golden Gate or, New England Services United or whatever the name is. You can compare. We can make a chart, show to our beneficiary and caregiver audiences, these are your options. This is what Medicare offers. These are the gaps. These are what the gap plans will cover. Can you afford that? Now we have to sandwich in always asking about their income, where they live, what their family and their medical history is in order to understand what Medicare Advantage plan might or might not serve them. Where do they travel? A lot more of personal, by the way, digging into someone's history. I wouldn't think many people who value privacy would like professionals to have to do that in order to choose the right plan for folks. So there needs to be simplification and standardization. If any of you, as I have had to choose health insurance for your employees, you know what it's like to make a choice every year. Most people who've had the good fortune of being employed have not done that for themselves all these years. And when they're faced now with Medicare, instead of it being a blessing and a simplification, it's hugely confusing. I have a friend who has a law degree and 2 PhDs who left me a message that he had a Medicare crisis. And the crisis was he had to decide what to do when he turned 65. So we need to standardize. If you're thinking about the beneficiary, there ought to be parity of payment between all these plans on a level playing field. And if MA can offer meals people in traditional Medicare should be able to get a meal. If MA is going to be able to do medically necessary oral health care and actually provide it, so should people in traditional. Otherwise, you're saying there's choice when you're actually putting a thumb on the scale. Medigap's expensive. In most states, once you make a choice, you can't choose again. It looks cheaper right away to get into a Medicare Advantage plan. It may not be. You may travel and get in an urgent situation and be covered right away, but not for the rest of what goes on with your care. So there's many things to think about, but standardization and parity as much as possible so that the consumer can understand this and know that the same value is existing regardless of their Medicare model is imperative.
I'll buy the standardization of terms, not the parity, because I think some models are more efficient than others and can use those funds differently. The notion of having people be able to more easily understand the components of the program is an appropriate one. I think there ought to be ways we can, of course, it does occur, it just doesn't occur to the same extent that Judy would like to see it. I think it's fair to say, let's see how we can make it an easier comparison to for the beneficiary or the beneficiary's advisors, who, after all, are actually usually the people that are helping the beneficiary make a choice, not some independent third-party person, as much as it is likely to be a family member or a trusted source through the person's church or senior community. But there are, I think, things we can do to increase the amount of standardization so it's a little easier to be able to make these choices. The fact is there are some differences in efficiency and advantages to some plans over other plans. They'll be important to some people, but not to others.
Thank
There are
you.
also some efficiencies in
Thank-
traditional
thank-
Medicare that are not to be forgotten.
Thank you. And Jen, before we leave Jen's question, I don't know if Jennifer or Emily had any comments specific for Jen's question. And if not, we can, no, okay. All right, Chinny, I think you had a question before we.
Yeah, I just wanted to hear the panel's thoughts actually on, our strategic vision is to support the vision of everybody, all Medicare members being in advanced payment or value payment methodologies by 2030. Now, obviously, what are the goalposts that you would recommend, or how do you recommend that transition, occur? We want to make sure we're thoughtful about what the position we take as far as that's concerned.
I don't know, Emily,
I think you need to decide on a limited subset of advanced payment methodologies that would be acceptable. We are still in a phase of Medicare development, payment development. It goes actually beyond Medicare and is true for private sector payers as well, where we are still struggling with defining the quote unquote best advanced payment methodologies. Hopefully by or before 2030, we'll be able to have agreement on a subset that we would like to maintain going forward. It would make everybody better off, physicians, other healthcare providers, and certainly beneficiaries.
Thanks, Gal. Emily, do you have any thoughts on that?
Yeah, I was going to say that if, to the extent that we can use data to empirically derive that answer to me, I think that would be powerful. I would start with, where are our Medicare patients getting their primary care today? How many of them are getting primary care, and how many still need to be better engaged in the system so that we can not only get them to value-based care and an advanced payment model, but get them access, period. And then start to think about the offerings that we have in each of those arenas. I think that the data is bearing out for physician-led and NP and PA provider-led accountable care models in advance of some of the hospital and health system-led models. And so we need to understand how to catch up for patients who do get their primary care and will be quarterbacked in a health system or hospital-based model. And I think we can start there, and would agree with Gail that we need to make sure that these models are really rich for all patients, regardless of where they seek their care, and make sure to not leave behind our patients who are disenfranchised from healthcare currently.
Great. Thanks, Emily. So I'm going to move to the next question and sort of combine the next two questions. In discussing how to enhance provider readiness to participate in population-based total cost of care models, from your perspective, what are some of the provider-level barriers to participating in these models? And also, as you think about these models, any experiences on how to structure payments to influence provider participation? So what are some of the barriers that you feel are there for provider participation, and then thoughts on how to structure payment to encourage participation? So Jennifer, I'll start with you.
Okay, great. Maybe just very briefly before I talk about a few of the barriers, maybe I'll just mention kind of there's four main ways that we, or four main questions, I guess, that we ask providers to start to gauge their readiness. And, they have to do with, is the provider kind of ready to make this transition over the next 12 to 18 months? Is there some urgency and enthusiasm there? Do they have a plan in place in terms of the resources, the services, the supports that they need? What gaps have they identified that we might need to help them fill? Are they aligned with leadership in terms of making this shift? And do they have some budget to support the transition? And so, providers who can answer yes to those questions are sort of more ready to move. Ones who can answer yes to the enthusiasm and leadership alignment, maybe need more support from us in terms of specific planning or budgeting. And so I think that gets into some of the barriers that we see. The first being that, the provider maybe doesn't have yet some of those factors in place that we view as important enablers of success in taking on more risk. And, some of those might be some sort of electronic infrastructure to help identify care gaps, perhaps linked to the EMR. Oftentimes, we see it valuable to have a care team around the providers that, do some of the patient management and other sorts of services. Are they successful in whatever value-based arrangement they have today? If they're doing some sort of upside only, pay for performance type model, are they consistently, getting to where they need to be on that they're, demonstrating the ability to take on more risk and financial risk, downside risk as well. So I would say lack of those things is a barrier that we'll work with them to address. Another common barrier that we see is often the patient panel size. And this is, more true, obviously, for the independent providers relative to the large healthcare systems. They may be too small to take on financial risk on their own without, coming into some sort of bigger model, or they might not have the economies of scale to do some of the population health management that we'd like them to do, at least not without a partner of some sort. And then another barrier that I would highlight can sometimes be what I'll call local market dynamics. So, on the one hand, you have the small providers who have, some challenges, but then on the other hand, you may have a very large, dominant, monopolistic, if you will, health system in a market. And while they have the right economies of scale and the right ability to take on financial risk, if they're not sort of interested in, kind of moving to more of a risk-based arrangement, they often don't really have to, right? Because they're a must-have provider in terms of a health plan's network. There isn't that same sort of feeling of, gee, I need to be engaged in a risk-based arrangement if I want to remain in the network, because they know that plans need them in the network. And that's not to say that there aren't plenty of large, dominant provider systems that are participating in these models, but we do see that as, sometimes a barrier to getting those larger systems on board. So to address the second part of the question, in terms of how do we, structure financial arrangements, I think generally speaking, there's the financial piece, but there's also the resources or the enablement piece. So as providers can take on more risk, there is the opportunity for more reward. I can't speak for, what other payers are doing, but I think generally as providers take on upside and downside risk, we share more of the savings with them. And so we generally work with providers to put them on a glide path, right? So providers at one end of the spectrum may need some more hands-on support from us. Maybe that's software, maybe that's help with care management or reports on care gaps. And, we can give them not only, financial incentives, but some of those resource incentives that help them move along the glide path towards greater risk and greater reward over time. And then at the far end of the spectrum, there are providers that have already made their own investments in this infrastructure and staffing and so forth, and they just want to be, able to do better or to, to get greater incentive to make those investments pay off. And so what they'll need from the health plan is data and a contract, and they're sort of ready to go. And then maybe I'll just wrap up and say, and this sort of gets to one of the questions that I think just came up. That said, our experience sort of suggests that at some point there's sort of a saturation point or a point of diminishing returns in terms of provider participation or in terms of patient attribution in the models. And, maybe this will change over time. But, generally speaking, the more providers or patients you get into these models, the more cost savings you see and so forth. But at some point, an extra provider or an extra panel of patients doesn't really equal the same sort of benefit or cost savings. And maybe that's because you reach a point where all of your sort of willing to be engaged providers are in the pool, or the providers that are left are just sort of too small to make a difference, or not really ready to be engaged. And so we probably need kind of different solutions, and I don't know what those are, but we probably need different solutions for that last X%, where today we see that getting them in isn't making the same difference as the first, Y% is.
Great, thanks, Jennifer. Gail, your thoughts?
I was trying to think back when I had initially thought it was time to limit the number of variations and decide how to define value-based payment and move on. And I think it was about 2017 or 2018. My inclination is it's time for at least the public payer, Medicare, to make some decisions about how best to measure value-based payments, implement that, and stop having quite so many variations. When I stop to think about the burdens we must put on individual providers, physicians and nurses, and other provider types, or institutional providers, I occasionally cringe. So I think that it has been important to try to increase and improve our knowledge about how best to redefine some of these concepts. But I think maybe it's time to do it. And that in and of itself would allow for a lot less burden on those that are providing care. Obviously, there will be points of time where there will be an agreement that some concepts need to be redefined or changed, and we should do that. Based on my earlier comments, it probably won't come as a surprise to say I'm much more comfortable having standardization of the component parts than what they have to all add up to, where I would allow for more variation for all sorts of reasons, because of state of knowledge, state of practice, attributes of the part of the country, or interest on the part of the beneficiaries. But I think having more standardization is the direction we need to move.
Great, thanks, Gail. Emily, your thoughts on provider level barriers and thoughts on payment structure?
Sure. I definitely agree with a number of the comments that Jennifer has made, especially that many providers need help to transition to value-based care, and that entry-level access to claims-based data is insufficient. The data and the insights you can get from it are pretty inaccessible to many who seek to transform care, and also essential to stratifying appropriate clinical initiatives. I think one thing that I'd like to really emphasize is what happens when you try to bring specialists into Medicare Shared Savings Program and other non-hyper-focused specialty-oriented APMs. It's really difficult to assign accountability to specialists who participate in a Medicare Shared Savings Program ACO, because most specialists are participating in care but not driving it. And they impact the total cost of care, but they're not quarterbacking it. And because attribution is assigned at the NPI level, if you take specialists into traditional total cost of care models, you end up accountable for patients you really are managing end to end, and lots of patients you really aren't managing end to end. And so think about, for that example, escalations in the frequency of specialist visits for nephrology and oncology patients who are undergoing an acute escalation or episode, right? You're going to have plurality of services in a specialist's hands, even if someone else is following their blood pressure, their coexisting diabetes, etc. And so I think the more we can anchor to primary care practices who are best positioned to quarterback the total cost of care, the more successful we'll be, which just means it is important to empower high-value referral and specialist management. We need to leverage all available data to help patients get the highest value care possible when they leave their PCP's offices. So I think Jennifer and others really covered the need for workflow redesign and a really different take from practices who are totally optimized to take in patients and care for what comes into their offices, and not really honed towards population health and understanding the attributes of the patients who aren't coming in. And so we need to overcome those barriers. It's years and years of training and practice to operate a business, and the business of healthcare is complicated, and shifting towards taking care of a total cost of care of an entire population is quite different. The more that we can incentivize innovation in the form of advanced payments or starters, there is also great fee-for-service. And I don't necessarily think that fee-for-service is a four-letter word. I think that there can be really productive fee-for-service when the design is optimized and oriented towards what the patient needs to get out of it. I think annual wellness visits are a great example. Transitional care management are really high-value visits that can prevent readmission if done well. And we've made a lot of progress with care management. And so I think when we do appropriate design of services that are reimbursed, it is easier for practices who are trying to survive in both models to leverage the fee-for-service services to the best benefit of the patient population. So investing more in primary care, where we can then expect dividends in the form of reduced emergency room utilization and unnecessary hospitalizations and readmissions, seems to be in our best interest.
Great, thanks, Emily. Looking at the time, and this has been terrific discussion, I'm going to move to the next question, which I think is a really important one, and be sure we get everyone's input. So equity is a focus for us here and was actually our last theme-based meeting, along with social determinants of health. So in your opinion, what are the potential equity implications of holding APM entities accountable for total cost of care in population-based models? And asking that both in general and for beneficiary subpopulations, such as historically underserved populations and individuals with chronic conditions. So with that, I'll start with you, Judy.
We certainly haven't found the key to fixing our inequitable society, and certainly not our healthcare delivery system. And I'm concerned that more and more diversity in how one receives your one's healthcare, and how you define quality within those healthcare models will not best serve vulnerable chronic people with chronic conditions and underserved folks. And I know that Commonwealth and Kaiser and others have shown that Medicare Advantage has in fact not demonstrated in fact that it serves those populations better. And our experience as attorneys, mostly for people with longstanding and chronic conditions, shows that in fact people who have such conditions often have problems with health insurance. They're not favored, if you will, to continue getting the care they need for the period of time and with the intensity that is required. And I think that reality ought to be seriously studied as these models are built, so that we know that we're incorporating the needs of people who need perhaps more intense care and or care for the longer term, and more health education.
Great. Thank you, Judy. Emily?
I'd like to start with the Medicare HCC risk adjustment model. There was a great paper by Brian Powers that was published a couple years ago now that did a systematic evaluation of how our Medicare HCC risk adjustment model, and many like it, systematically underestimate the risk of Black patients versus white patients. And that is that at the same HCC risk score, and for those who aren't deeply initiated in this, the HCC risk adjustment methodology is actuarial, and it takes into account all of the patients and the patient populations diagnoses that have been seen in the calendar year, evaluated and billed. And so what you see is that because of delays in diagnosis and healthcare inaccess that's really borne by the 400 plus years of structural racism in our country, at the same HCC risk level, a Black patient is much more likely to be sicker than the white patient. And it's just true that a lot of organizations use HCC score as a stand-in for clinical acuity and absent of any other indicator, and use that score to identify and stratify patients for additional clinical services and benefits. So I think a first step would be that we really need to adjust our risk adjustment methodology to account for this finding and potentially reduce disparities in the provision of extra clinical services and attention to patients by risk adjustment level. I've been encouraged by the progress with the area deprivation index. I think it might be a step in the right direction as a payment innovation, and I'd love to see more in payment innovation that honors that social complexity is expensive, but also makes further downstream resources available rather than simply bonusing up the care of socially complex and economically disadvantaged populations. So the more that we can actually care for these populations by making social determinants of health screenings more mainstream, potentially paying for them with good fee for service, and connecting patients to resources. A lot of good data on community health workers. How can we incentivize that and make that mainstream here? How do we pay for the downstream resources once we identify patients in need and embrace that in advanced payment models?
Great, thanks, Emily. Gail?
Yes, few closing thoughts. I was a little surprised by Judy's comments with regard to the use of Medicare Advantage in its various names by lower income individuals, since for a long time, and to some extent still today, minorities and lower income individuals have disproportionately made use of Medicare Advantage as a way to increase the benefits that were provided, and as a Medicare Advantage proponent for its potential ability, not always realized, to integrate services in a way that is even more complex for the traditional Medicare program to do. I have been happy to see that. A comment with regard to the social determinants of health and how to try to bring them more into the Medicare program, or the Medicare program more into the concept of social determinants of health. You decide which way best to go do it. It would be enormously helpful if we could see some significant consolidation of the many programs that exist, sponsored by the federal and state, or federal, state, and local governments, into a smaller group of services. There are many overlapping and competing programs, and they make it much more difficult and complicated to unify the services that we are trying to provide to needy populations. I think our potential for being able to incorporate the social determinants of health, or at least some aspects that are most directly related to medical care, would improve considerably if we were able to do that. It is frustrating to me that it's an issue that I know I personally have been speaking and writing about now for 30 years, and do not see a lot of evidence of movement in that direction. And some of this funding so much better and more wisely if we could find a way to have more rational consolidation. I'm open as to who gets to be the consolidator.
Great. Thanks, Gail. Jennifer?
Thanks. Yeah, I'd like to kind of loop back, I think, related to what Emily was talking about. How do we think about the various levers that might exist to drive improvements in health equity through these total cost of care or value-based payment models? And I think to start, we first probably need better, more comprehensive and more complete data to know where the inequities truly exist and how to best address them in the first place. I think as plans, as CMS, we probably have good data on the communities that we're serving, disparities at the geographic level, but I would say we really don't have nearly as complete data as we'd like to have on individual level data. So even race, ethnicity of members and health plans, or better information about health-related social needs. There's certainly been movement to collect, what are known as the Z codes, but I think that's still pretty spotty. So, how do we encourage, first, better identification of where the needs exist at the individual level, and then actual, improvement upon those health inequities within value-based care models. I think one thing you can think about is how do you include some measures around this in the so-called kind of quality gate of your total cost of care models. But I think we also have to be careful to balance that with how do we ensure that we're not unduly penalizing or disadvantaging those providers who may see a greater share of patients who have those health-related social needs, or who are seeing populations who are historically underserved, have more chronic conditions, and so forth. How do we ensure that they're not being sort of downgraded, not because of true performance, but because of inequities in their own practices. And likewise, we have to think about, what's fair to ask primary care providers to take on. Some things may not really be within their capability to do within the medical setting when we think about this broader set of social needs. Large health systems have the infrastructure in some cases or want to have the infrastructure to address these things. Smaller practices, independent physicians, they just may not be able to do those things. So I think we have to think about what's the right structure, what's the right framework to improve health equity, in what circumstances do we want providers to be accountable for some of these things or to take the lead? When might it be the health plan? When might it be a partner or a vendor? When might it be the government or some other entity that's best situated to be responsible for these things? So I think it is a goal that we're all working toward for sure, but we need to be thoughtful about where the resources are and how best to deploy them.
Great, thanks, Jennifer. And I realize we're over time, but if our panelists, we'd like to, this discussion's been really rich, and we'd like to continue for another 15 minutes if all our panelists are available. If so, maybe I'll open it up to PTAC members if you have any questions on this topic of equity.
I can stay on for about another 5 minutes. And then I
Okay.
need to pick up another Zoom.
Okay. Thanks.
Same. I have another call, and I can stay for
Okay.
another 5 or so. Thank you very much.
Okay.
I was just going to follow on Gail's comment about consolidation, Paul. I think that's such an interesting comment nationally. So I work deeply with underserved and marginalized populations, and the proliferation of organizations trying to meet social needs and the underfinancing and resourcing of those organizations is a real issue. And the coordination into integrated networks with supported leadership and contracting and financing is so important as we look at meeting equity and meeting social needs in our communities. So I just wanted to follow on that comment. I thought the consolidation piece is critical in what I'm seeing on the ground in different communities. I didn't know if you wanted to say any more about that, Gail.
Just as somebody who has worked with a variety of these organizations because of the various hats that I have worn over the years, it has come up numerous times, the concept that there are overlapping programs that tend to make dealing with as broadly conceptual idea of the social determinants of health more complicated because they have their own constituencies, they have their own groups that they have to report to in terms of power structure, to use a phrase, that if there could be more consolidation, it would allow for a much better integration. And since the whole concept of social determinants of health really is to integrate the medical and social service components that are necessary to improve health and well-being, it is part and parcel of the objective. So it is very hard because each of these groups have their own political constituencies. They frequently will have their own interest groups who support them, and the political, both big P and little p challenges of trying to have consolidation is formidable. I've been on a couple of groups that have made faint-hearted attempts to try this, but it really is keeping us from accomplishing the goal. Many people, for many reasons, have commented it's not that we don't spend enough money, it's how we spend it and how the care is provided that gets in our way. I think there is widespread agreement across people of very different political persuasions. It's figuring out how to crack this that has proven so challenging. So thank you, Lauren.
Yeah, completely agree.
Any other, and I know we're pretty much out of time, any PTAC members, last minute questions for the group, for this great group of panelists? Okay, if not, I want to thank on behalf of the committee and our audience, each of you for your insights today. We're grateful. You've certainly been generous with your time and sharing your expertise. If you can stay on for the remainder of our meeting, we would certainly welcome you. Again, want to thank you all for participating. So with that, I'm going to move to the public comment period.
Thank you very much, Paul, and everybody. I really appreciated participating. Thank you very much.
Thanks, Judy. Thanks, Jennifer and Emily.
Thank you.
Yeah. We have one person who has signed up for public comment. I will introduce them, and then our moderator will unmute so that you can speak. So I want to open up to Sandy Marks, Senior Assistant Director of Federal Affairs at the American Medical Association.
Thank you. So last fall, the CMS Innovation Center staff asked AMA to identify barriers that prevent ACOs from partnering with specialists and ways to encourage specialists to engage in an integrated model like an ACO without financial risk sharing becoming a point of contention. They also wanted feedback on related questions dealing with attribution, overlap, and improving care coordination and equity. To address these questions, we drafted a payment model proposal, which we are calling Payments for Accountable Specialty Care, or PASC. Here's how it would work. Specialists would enter into voluntary agreements with ACOs to improve care for ACO patients with certain health conditions in a way that would help the ACO meet its overall quality and spending goals. For each patient referred by an ACO primary care physician to a specialist with a PASC agreement, the specialist would get an Enhanced Condition Services, or ECS payment, to help support comprehensive diagnostic workups and use of patient-physician shared decision tools and clinical pathways to arrive at an accurate diagnosis, patient education about their condition, treatment plan, and self-management to improve outcomes and prevent exacerbations, and assistance to get tests, medications, or therapies that require scheduling or prior authorization. With concurrence of the primary care physician, additional payments, called continued ECS payments and special ECS payments, would be made if the specialist needs to continue treatment after the initial month, or for patients whose care is significantly more challenging due to social determinants or other factors. Specialty societies and organizations representing ACOs would help develop a standard template for the PASC agreements, specifying how appropriate patients for referral to the specialist would be selected, how specialists would coordinate with primary care, quality or utilization measures related to the condition and target performance levels, and data the ACO would provide to support care for the conditions listed in the agreement. Much more detail is provided in a discussion paper that we've shared with CMI. Some benefits of the PASC approach are that more specialists might decide to participate in ACOs, more ACOs would engage with specialists, primary care physicians would have a basis for choosing specialists for referrals and getting feedback from and coordinating care with them. Performance measures would be appropriate to the conditions in the agreement, so there would not be repayments tied to factors that specialists cannot influence. We'd be happy to share the discussion draft if you'd like to learn more. Thank you.
Thank you, Sandy. So I'll check with the host before we move on. Are there any other folks who wanted to contribute?
No additional comments.
Hearing none, that is the end of the public comments. We are now going to take approximately a 15-minute break and then return for the committee discussion. So we'll plan to return at 3 o'clock and we'll begin our committee discussion at that time. Thank you.
Produced by the U.S. Department of Health and Human Services.